Hello and welcome to our first Health on the Plains coffee hour of 2026 today and continuing on the third Wednesday of the month through October. I will spend this hour with a nice cup of coffee and with you all and with a great thinker and thought leader in the world of rural communities and rural health. Now, we know this time doesn't work for everyone, uh, so we'll be recording this conversation. If something resonates with you today, we would love if you would share it with your colleagues. My name is Wyatt Beckman. I'm a senior analyst and portfolio strategist at the Kansas Health Institute, and I'm thrilled to host this series. This is our second year of the Coffee Hour series. The Kansas Health Institute is a nonprofit, nonpartisan educational organization based in Topeka. We believe that evidence-based information, objective analysis, and civil dialogue can inform and support effective policies, programs, and interventions for healthier communities. This series is built on the idea that nuanced conversations with thoughtful people can help us better understand the many factors that shape rural health. And with that better understanding, we can all work to envision and implement more effective strategies and policies with and in our rural communities. So, what is the central story of rural healthcare in 2026? Is it one of challenges and losses? Is it one of opportunity and innovation and transformation? Is it some of both? And ultimately, how do those stories of rural healthcare help us navigate the path ahead? Here to wrestle with those questions is our guest, Sarah Jane Tribble. Sarah is the Chief Rural Correspondent for KFF Health News, where she leads their in-depth reporting on rural health. She created the organization's first narrative podcast, Where It Hurts, about the closure of Mercy Hospital in Fort Scott, Kansas. An Emmy winner, she has received honors for her work from the National Press Club, the National Institute for Healthcare Management, and the Association of Healthcare Journalists. Before joining KFF Health News, she covered the healthcare industry in Cleveland for NPR and PBS and spent more than a decade as a reporter for major newspapers from the Carolinas to California. Perhaps most notable of all, she grew up in Southeast Kansas, and she brings that Kansas lived experience to the stories she covers and to this conversation today. Sarah, thanks so much for joining us.
Thank you for having me, Wyatt.
Well, I hope you have a nice full cup of coffee and you're excited. I'm really excited. Perfect. I We're going to talk a lot about the work you've done, the stories you've covered, the people you've talked to. And as I noted in your introduction, you're in the business of telling stories and covering other stories. But I wanna start uh, with your story because your story started here in Kansas. And on your LinkedIn page, there's this background photo, and I'm going to share it on screen here. And this looks to me uh, like it could be a parent with some kids on a farm in Kansas. So tell me about this picture, some of the people that are in the frame and how that relates to you getting into journalism and starting your career.
Well, thanks for asking about it. It's funny because I was just thinking it was time to change it. I put this picture on my LinkedIn page when we launched Where It Hurts, the podcast that I know that we'll be talking about. This picture is my father, who is a life inspiration for me. He didn't graduate from high school. He went to Vietnam. He worked in a factory for 40 years, and he was a wonderful father. And this is on our property, the driveway to my home, my family home, where my parents still live on that dirt road in southeastern Kansas. And I am the little one with my older sister Maggie. And this represents how much everything I love about growing up in Kansas. The open air, the beautiful view. I think it's gorgeous. I love going back and sitting on my parents' porch now, and my parents who just are really inspirational, wonderful people.
Awesome. Thanks for sharing that. And if I had to guess, that's what I would have guessed. It was dad and sister. I'm gonna stop the photo. And thanks for not changing it before I could use it to segue into the conversation. And I know this is some place you went back often in some of your reporting, and it's where I wanna start digging into some of this work, and I think that context for where you grew up and your family's connection is gonna keep showing up. You know, your reporting for Where It Hurts was back in 2020 and 2021. And that was for a podcast series called Where It Hurts, and it was on the closure of Mercy Hospital in Fort Scott. And across 7 chapters, you talked with people from all different parts of the community, people in leadership, people that were patients, people in all walks of life. And it was a really well done series, and I encourage folks to go back. What I noticed though as I listened back is how relevant those challenges are still today. From 2005 to 2026, there were 108 complete hospital closures across the country. Another 88 hospitals converted and no longer provide inpatient services. And that's continued in the years since you wrapped up that reporting. So unfortunately, that challenge of hospital closure seems to still be one that is a key challenge and central to the story of rural healthcare today. So tell me a little bit about covering that story, some of the insights or lessons that stood out to you that unfortunately still show up today, perhaps.
Yeah, it's thank you for bringing it up. I am consistently surprised by how it's resonated, this podcast, and how it continues to have legs, as we call it in the business, right? And I think anybody who was at the National Rural Health Association meeting in San Diego would know that I like to return to Kansas. I'm going back there in August to help celebrate my dad's 80th birthday. So, in reporting the podcast, I like to tell this story if we have a moment. I had a call from my mom, who said, Fort Scott's closing, and I already had known that Independence was closing. Mercy had closed Independence a few years prior, and so I walked up to the editors and said, "Hey, uh, this is 2 hospitals in the same region without Medicaid expansion. And if you're looking for a story with non-Medicaid expansion and what's happening to hospitals, this could be one of them. It sounds like their CEO is speaking out." And nothing happened. Nothing at all, like for a couple of months. And then the executive editor stopped me in the hallway on the way to the stairwell on the way to get lunch. And she said, "Do you think you can get to that hospital in Kansas before the end of the year?" And it was early December. And I knew I could because I'd been flying back frequently to visit my sister who was sick with pancreatic cancer. And so I knew the flight schedule. And I said, "Yes, I think I can." And anybody who knows Rita Baker, I haven't talked to her in several years since the podcast, but you'll know that she's a generous, caring, passionate individual. And she worked with me. And when I got back from that reporting trip, I had a very long story. And my editors were like, these are really interesting people. You have to do a series of stories. And so that's how that got started. Now, as for your question about the relevance today, which is remarkably sad, I guess is the best way to put it, are these challenges, right? So we decided to do the podcast on topical areas. And if you were to listen to it, you'll understand there's an episode on emergency services going away. There's an episode on cancer services going away. There's maternal health care going away. And there's behavioral health challenges. And so these areas are very relevant today. And as we continue this conversation about the Rural Health Transformation Program, you'll see them pop up again.
Yeah, absolutely. And I know I again invite folks to listen to it. And it I think you did a really great job of showing and giving people the space to share about the challenges that they were working through, but also a lot of the strength that people had in working through those and making the best of uh, the options they had, and even a lot of humor came out, and it's a unfortunately, as you said, those topics and the challenges around healthcare for those topics in rural communities is something that's going to keep coming up and likely come up as we keep talking. You also mentioned expansion in Medicaid, and the topic of Medicaid is one that also has come up in a recent central story in rural healthcare, and that's around HR 1, or the One Big Beautiful Bill Act. Among other things, many things, HR 1 included a couple really key elements that folks that are interested in rural healthcare have been focused on. One was reductions in Medicaid reimbursement, changes that are projected to hit rural providers, rural communities particularly hard. The other was Rural Health Transformation Program, or RHTP. If you hear us say RHTP, that's what we're talking about. It's uh, can be a mouthful. But RHTP, Rural Health Transformation Program, provides funding to all 50 states to transform and improve rural healthcare. Before we really dig into the Rural Health Transformation Program and some of the reporting and stories you're hearing about that work across the country, tell me a little bit about the relationship between those two key elements, the Medicaid changes on one hand and Rural Health Transformation Program on the other, and how that shaped the design of the Rural Health Transformation Program that we're going to talk more about as that's rolling out across the states.
Yeah. Well, let me start by saying if you are a hospital executive or leader and you had the impression that the Rural Health Transformation Program was supposed to help you, you weren't wrong. That's what the politicians said when they passed it. So, the reductions in Medicaid spending coming down the pipe are nearly $1 trillion over a decade, 900 billion roughly. And in rural America, according to the KFF policy side, it's 137 billion for rural America alone over a decade. There's another foundation in Kansas that has estimated that's going to be $4 billion hit for Kansas alone, with about 13,000 people losing Medicaid coverage. And the folks on this call know the reasons. Medicaid didn't expand, so it's not getting hit as hard as some other states, but there's other provider taxes and other things that have been a big conversation in Kansas that I am no expert on. That said, there's cuts coming, right? There's a reduction in the amount of money going to providers who have a lot of Medicaid patients across the country and in Kansas. The idea was that the 50 billion would help offset that, right? That it would help make up for all these cuts coming down the line. And that was the conversation in DC. And I remember I was sitting with a group of health leaders the weekend of July 4th, 2025. And I was sitting in the back of the room because that's what I like to do. And 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 people started getting text 15 million, billion, 25 billion. And then it got up to 50 billion by the end of the weekend. And that was because senators were negotiating to get more money, right? And so they got more money. And they wrote a very interesting law. If you read it, it has like prescriptions of how the money should be spent. When the NOFO came out, when the notice of funding came out, though, the application, it didn't focus necessarily on hospitals themselves. It focused on transformation. So the connection there got more tenuous, if you will, for it helping directly rural hospitals and clinics. One can argue it will definitely help those, but one can also argue that the money is truly steered at technology innovations and other transformative ideas.
Yeah, that word transformation, I think is one we're gonna dig into a little bit and some of the implications of that focus. I want to pause for a second, remind folks in chat, in Q&A, if you have questions. It looks like the chat is there. Drop your questions or your comments, and we will bring those into the conversation. So transformation, thanks for that background, because it can be easy to hear both of those two things happening and say they're a one-to-one match, but it's not, it wasn't written that way or designed that way, and both are happening at the same time, but certainly the anticipated challenges associated with the reductions on the Medicaid side are part of the context for discussions around what the Rural Health Transformation Program can and will do. One question that I think sits through that, underneath that, that I also heard come out of your podcast even 5 years ago, over 5 years ago, is the question of what health services should be available in rural communities. And I heard different answers to that in a lot of ways. That, the question of what are those essential foundational things. So when we look across rural communities, we say every community should have that. And historically, I think the story of rural healthcare has centered a rural hospital in that answer or in that picture of what should every rural community have. And for good reason. Rural hospitals are really important, both for healthcare access, but broadly across a community. But we know that for some communities, that hospital is no longer there in the same way. It's no longer part of that picture. It's not part of the answer, at least not right now. But the need for health services is still there, right? And a foundational approach, as you noted, of rural health transformation program is the idea of transformation. How do we envisioning new approaches, new forms of healthcare, modernizing? So, in your conversations with policymakers, with those implementing these programs, how are they wrestling with that fundamental question, and how are they balancing meeting current needs, working within this current delivery model, the current picture of what it looks like in rural communities, with a push for innovation and new approaches and new models?
I mean, I think this is the big question, right? Like this idea of we know what we've been doing doesn't work. In fact, I've heard CMS leaders, some who helped create the application, say on the record that you don't want to throw good money at something that hasn't been working, right? We keep putting money towards rural hospitals and they still keep failing, right? And it's because patients aren't showing up there. And lots of people have different opinions on why that's happening. But one thing is true, there's a bypass effect for a lot of hospitals. And it's also true that, and I think we all can admit this, that rural hospitals don't serve the same purpose they did when Hill Burton was created and paid for the building of all these massive infrastructure projects, right? And so, really, the question that I think a lot of policymakers who acknowledge this are grappling with, state leaders, for example, they know that these old buildings where there are hundreds of beds in some cases or more beds than are needed in today's modern healthcare system, that's not really the answer for these communities. The challenge is having the financing to transfer to what is next, right? And to know what is next. And I think that all the smart policymakers I'm talking to are wrestling with this question in different ways. I can talk to a startup company out of California who's very excited about analyzing claims data and identifying those patients in the managed care network, the Medicaid managed care network, that maybe haven't gone to the doctor on a regular basis, but have gone to the ER and then sending somebody out to their home, right? I had that whole conversation with somebody in one of the northern states. And she was very excited. She had proof and data, and that may work. But then I can talk to a rural clinic provider in North Carolina, and they say, we just need more doctors. We just need more offices to take care of the people who keep showing up because all these places have closed. So I think that if you're, depending on the position you're in, you're grappling with a very different fire in front of you. And the challenge is, and I heard a very smart national rural health leader say this, Kevin Bennett, who's out of South Carolina, you get this 50 billion, but it's like getting your leg cut off right before you're told to run the race,
Yeah.
right? Like you've had the Medicaid cuts, but your leg's just been cut with those Medicaid cuts. And now you've got a 2 to 3 minute head start compared to the other runners because you got that 50 billion, but you still have to run the race. And so if you're dealing with that firestorm of not having enough providers, of people who come to your door and they have multiple social determinants of health challenges, if I'm a doula or somebody working in the community and trying to help those people, those problems are very front and center right now. And the idea that transformation dollars may be going to improve an electronic health record system sounds great. We all know we need it, but it may not be the thing that you need right now. And I think that's really where the conversations are right now.
As someone who runs recreationally, at least the idea of getting my leg cut off right before a race sounds particularly unfortunate. So that's a very vivid example or metaphor analogy. You mentioned doulas. Someone in our chat asked a question about doulas, and it sounds like they are a doula. And their question was about connecting with rural families who may not have access to care. What have you heard about doulas in the context of the Rural Health Transformation Program or even outside of it? And what are some of the maybe some examples you've heard about doulas connecting with particularly those that are uh, not getting reached or underserved?
And I think this is an area that is rich for stories, frankly, as a reporter. We've heard about doulas, and I know they're not the same, but community health workers, other people who have a very tangible on the ground experience with patients and people in the community who often can be frequent flyers, if for lack of a better word, right? Or they're in a position to really be open to healthcare access when you're having a baby. That's kind of an entry into the healthcare system that then can establish a family well if you do it right, as the research shows. What's exciting to me about the rural health transformation programs that I'm looking at, a lot of the states are doing doula work or community health service workers work or some of that on the ground work because they know that that's what works in their community. So states are trying to funnel grants and things towards those projects in some of this. I don't know Kansas is as well, so I can't speak directly to the Kansas one. But I did see community health workers, not doulas, but it may be in there and I just didn't see it. So that is exciting. Now, back to the question of if I'm on the ground connecting services, there's also a few states, North Carolina, Missouri being two of them, that are putting some of these dollars towards these social determinant platforms where you can connect people, doctors, providers, with a platform that then tells them these are the 5 services this person can qualify on Medicaid, right? And so that is happening, or at least it's in the works in some states.
And maybe some foundational or background context. If folks are less familiar with the Rural Health Transformation Program, overall goals for the initiative or framework at the federal level, but then each state came up with their own plan and is going to implement to achieve that plan over the life cycle of the grant. So we will have sort of similar approaches, but different ideas and different strategies, similar topics, different strategies all across the country. Um, One thing that I'm thinking about in that is the potential for us to learn from all these different approaches and is there a space with that goal of transformation and innovation that we can take what we learned from North Carolina and apply it other places. Has that been some of the conversation that you've heard? Is this idea of we've got, for lack of a better expression, we've got this lab where we're going to run a bunch of different tests and experiments. We're going to try different things, but is there intentionality about also learning from each other? And how do we do that well?
Yeah, actually, you mentioned the word lab, and there is a Health Futures Lab based out of DC with a former state HHS director, I think. Krista Droback is her name. She helped create this to convene conversations between states. It's also something the CMS leaders have really encouraged is this convening of conversations between states, swapping ideas. So that definitely is something they want to see come out of this 5-year plan. And and I default into talking about this oral health transformation program because it's my main beat right now. We've got lots of folks at KFF Health News covering Medicaid as well and other areas. So you'll see a lot on our rural page. But the 50 billion rolls out over 5 years. Kansas got 222 million during the first year. Again, that doesn't offset Medicaid cuts, and the timing is different than the Medicaid cuts coming down the pipe. So they're not one for one. But that said, these ideas are supposed to help uh, bolster care in rural communities and improve health outcomes in rural communities. So if you're a healthcare worker on the ground, that's really what it's aimed at doing. And Mehmet Oz himself, the CMS administrator himself, has said we think rural America can be a leader in helping us come up with solutions for urban areas too. And so at the highest levels, they're looking at this project as an example of how to get ideas and benefit everybody in the US.
Uh, one question that I think our first question chat alluded to, those rural families who may not have access to care. Ultimately, all of these rural health transformation program strategies and efforts are designed to support rural health, to support rural communities. Um, but in a lot of cases, organizations, businesses, other groups that are not based in rural communities are going to play a big role in implementing these programs. One question that I've heard, both from those who are implementing these programs and designing them, and also those who are wanting to be on the receiving end or excited about the potential to receive these funds, is how do we make sure this funding reaches those who really need it? Have you heard that question come up? How are folks thinking about that question?
It's everybody I talk to from and hear from a federal level to a state level to a community level, they're very cognizant of this question, right? Um, and the reality is the dollars will go to big companies. Many of them will. It just sort of that's the way the program is set up. But it will also go to small community organizations. And that's just going to take a little bit more time. I was excited to see Kansas come out with a list of grants already directly to places like Fort Scott and places in southeastern Kansas. And so it's really dependent upon those state health offices and department directors to make sure they're talking to the people that they know on the ground and get the money to them. At the same time, from a federal perspective, I've talked to lots of big companies, the Deloittes, the Gainwells, um, the big companies that already do contracting with state offices for Medicaid, and they are in a position to hire, team members who can directly talk to state offices because they already have those relationships, and then to say this is how we can manage the infrastructure, the technology infrastructure. And these companies have the resources to then pitch their partners, their AI partners for different projects and so forth. And so that will also be happening at the same time. So, as a reporter, what I'm watching for and what I'm asking is which states are really getting that money to the ground? And also, how beneficial are those technology infrastructure changes? Because while you can say these big companies from the outside, they're not on the ground treating patients. And so, maybe the money should go elsewhere. The reality is there hasn't been enough money for rural clinics and hospitals to really up their game on, electronic health records or the other things needed to make things more efficient for their providers to get the job done. So it's kind of twofold for me as somebody, as a layperson, kind of sitting back and watching this, but also having gone across the country talking to people. I think that the question of will it reach rural communities is a more complex question than on the surface, I guess is the best way to put it.
Yeah, like a lot of things, more complex than it looks from the outside or on the surface. You mentioned technology. Technologies is a really central piece to this rural health transformation program. And I think even outside of rural health transformation program has been in the discussion about rural healthcare for a long time. You mentioned earlier a lot of the facilities were built long ago, and there's large expenses associated with modernizing and technology. This is an area you've covered for years. You had a series of stories on what you call dead zones, places that have gaps in both healthcare access and broadband access. more recently, you had a story about Alabama and their plans to use robots to fill gaps in maternal care. And like many discussions and maybe people's reactions right now, that was met with some mixed perspectives.
Yeah, I mean, it
Uh,
sounds crazy. Robots taking care of rural moms in the deep south. Like, it just sounds on its surface. And so when Mehmet Oz, when CMS Administrator Oz kept saying it, I mean, he kept touting Alabama's great idea. And so finally I was like, okay, I've got to find out if it's a great idea or not. Like, and it turns out that in Canada, they are seeing huge success with telerobotic arms that are controlled by community health workers, trained community health workers in the remote areas of Canada. And then the readings are sent back to a sonogram reader in a more urban area. And so it's working. They've seen success in making sure that people get their prenatal appointments done because they don't have to travel from their villages hundreds of miles to the medical center. And so, from a global standpoint, it can be very quite successful. And when you ask about the infrastructure, of course, they were using satellites in some places to get the broadband access, but it's not a high end infrastructure thing those telerobotic ultrasounds use. Alabama's plan has money funding for crash carts at rural places as well as these ultrasounds. Um, but if I'm an obstetrician, if I'm an OBGYN working in a rural community and I know my patients, I have my doubts about how well this will work because it's one thing to have somebody with no complications come in and have a sonogram done by somebody who maybe isn't a highly skilled doctor. It's another thing to have somebody with multiple complications come in who maybe needs care right away. And I don't know the data on how often that would happen in some of these rural areas. But when I talked to OBGYNs about this idea in Alabama, they had their concerns because their patients, when they come in, it's not just an ultrasound, right? It's many other things too.
and I think the other thing that brings to mind for me is this idea of is or question that I hear come up is robots the option? And we're using this as an example of sort of a technology based approach. Is that enhancing and supporting the best possible quality care we can get, or is this the alternative to what we would want? Is something better than nothing sort of line of thinking? Is that part of how has that shown up? Has that question sort of been wrestled with in rural health transformation program or some of these other related things we think about hospital conversions going from a full hospital to a rural emergency hospital, reducing or eliminating that inpatient component. That that sort of underlying question is something better than nothing, and is are we accepting less than ideal in some of these cases?
Yeah, I don't have the answer for that. And if anybody who's listening to this does, they can chime in. Um, it's something I ask in every community I go to, and you get mixed responses, right? Um, One of the statistics that sticks with me in this part of the conversation is maternal care, right? Like if I'm only delivering a baby a month, my quality metrics may not look the same as a place that's delivering hundreds of babies a year. That's just a reality, right? They may be better, they may be worse, but a place delivering more babies probably has more resources and skills and can deal with situations differently. But does that mean there shouldn't be somebody delivering babies in that place that only has one baby a month? Does that mean that a warming blanket and an ER is good enough? That an ambulance ride is good? I don't know. I don't know the answer to that, but I do know that as somebody who's had kids, I would want all the resources I could right there in my community, right? I don't want to have to travel 2 hours for the, the the experts who can help me. Um, and I've interviewed family doctors who have been trained to deliver babies, and I find that to be a very useful example of what can happen in rural America. Now, the question of what if nothing is better, if something is better than nothing, right? Um, what I the reason I think it's worth covering the rural health transformation program as a beat is because of this question, right? They're trying to figure out what's going to work in places where you don't have high volumes of people. And lots of experts have presented ideas over the years. And the rural emergency hospitals has like a retaining fee, right? Like every year you get $3 million if you get that rural emergency hospital. You go without things like 340B and swing beds, but you get that standing fee, right? And so those sort of details just show how Congress has grappled with how to support rural communities and what that question looks like. Um, but in reality, as somebody from southeastern Kansas, my gut tells me that we want to deal with people. And you know, I interviewed a woman named Barbara in Alabama, and they had a telehealth booth, and they were very excited about it. And Barbara has laughed at me when I asked if she used it. Um, she's like, I can drive. I can drive the extra 40 minutes over to Greene County Hospital, um, which is really interesting because Greene County Hospital's metrics weren't amazing when you look at their quality metrics, but she loved her care provider. And that meant she was getting the care that she thought she needed. Um, and so I think telling those stories about people like Barbara and others can help, like, just add to the conversation about what is valuable, not only in rural America, but really for everybody. And my biggest desire, and I think, I don't want to sound like an advocate because I'm a journalist, but as a journalist, I think about fairness. And I just want folks in rural America and everywhere to get their fair share, right? Like, I don't want people to go without care just because of where they live. We all got telephone lines. We all got the post office. So surely America can come up with a way where we all get the health care we need, just like those in metro and urban areas.
Yeah, and the example of Barbara is, uh, I think, emphasizes the value of relationships and people wanting to have that healthcare relationship. And it should not be lost on us that technology is amazing. We couldn't be having this conversation right now without it. And at the same time, it it I think the fundamental question that a lot of people are wrestling with, and people that are smarter and know more about this than me, is how does that technology um, enhance and support that, not take away from it. And
Yeah.
that I think will continue to wrestle with, and states are thinking about that. I want to go back to something I mentioned because it's sort of on this topic of technology, but connects it back to some of the underlying context and infrastructure that we envision, or that we hope we have these new solutions, this modernization that's going into a context that sometimes might make that difficult. Not always, but I'm thinking about the dead zones.
Mhm.
Tell me a little bit more about the dead zones, how you define that, and that connection to where that could present some challenges for some of these solutions that we're thinking about.
I'm going to take a sip of coffee to prepare for this.
Perfect. And while you do that, I'll mention that there's a question in chat about the uh, grant list, and it looks like about the grant list for KDHE and the Rural Health Transformation Program. Watch for our recap. We will link out some
Yeah.
resources so folks can follow that. It is something that is being publicly shared, so it's we will share that in the recap. But back to the
Mhm.
dead zones.
I will answer dead zones, but I will also say that there are several national trackers for RFPs, grants that are coming out. NRHA has one for the states as well. That's the National Rural Health Association. If you go to their page, you can see a tracker for the states. KDHE may have it up on their website. I have not gone and looked. They certainly have their press release of where the grants went. And I'm sure there's more grants coming. So if that's what you're interested, go to those trackers, go to your state website and look, because um, go get that money. It's out there. Now, the dead zones. I was actually in Kansas when it hit me. I absolutely had to do a story on it. And I put up a note on my billboard at home and said, well, it used not a kind word, but it was basically F broadband, because I cannot tell you how many times I went to communities working on Where It Hurts or other places where They, even in the community, they're like, we have 5G, just use it over here at this coffee shop, and it would not work.
Mhm.
And I'm like sitting outside a library trying to record something for National Public Radio, and a storm hits, and I can't do the recording because I don't have internet, because my parents didn't get internet until just a couple of years ago, a high-speed internet. And anybody who uses dial-up knows, whoever used dial-up knows how it is in many places, and at least a dozen counties in Kansas, according to our last analysis, we're still lacking high-speed internet as well as enough providers. So dead zone was this idea to map the U.S. with the latest FCC data on where there was not enough high-speed internet. A certain percentage of people in the community lacked it, as well as not enough healthcare, primary care providers, and behavioral health providers. We did not use HIPSA data. We worked with George Washington University on some data that they had that was a little bit more robust, according to my data analyst folks at KFF Health News. That maps up. We have not updated it in the last year-ish, maybe 8 months. And I don't think we're going to update it. But I do know that funding has been going out to communities, both from the CARES and ARPA Act, but also BEAD money is starting to go out. Anybody who's followed the FCC and what's happening with that money will know that at the beginning of the year, the new Trump administration, Trump 2.0, as I like to call it, revamped that Broadband Equity Act, and told states to go back to the drawing board to include basically more satellite in it. So states did that. Some states were affected more than others. But the money is starting to flow from that BEAD dollars to states now, from what I understand. I need to do an update story on that. So that's where that stands. That said, if you're in an area that's lacking high-speed internet, it's really hard to say people should use telehealth. Going back to what you said a minute ago, Wyatt, about the advantages of technology, obviously we're on here now, but sitting in DC, people love virtual healthcare, right? Like I would personally, I would prefer to do a virtual appointment when I can, with myself or my teenage kids. It's faster, easier. I have a great relationship. I can email with my provider anytime. Like it's an ideal relationship. But I am also a very educated, like I've been covering healthcare for 20 plus years. I know exactly how the system works. I know exactly what to log into, what questions to ask. To make that leap to somebody like, say, and I'll use my mom, she's in her 70s and she's never had to do any of that. And she is doing it. She works with the VA, she does these things, but it's not a natural thing, right? And she will be the first to say, Sarah, can you do this for me? And I think that's a lot of people, especially older folks in rural areas or even non-rural areas, who maybe don't feel completely comfortable with technology, and what seems easy to many people is more of a challenge. And I think we need to honor people where they're at.
Yeah, it's another example I think of these opportunities, these challenges. There's the initial view of it, and it's like, oh, that makes perfect sense. And then you go one peel back a little layer, and you're like, it can be more complicated, it can be nuanced, and there are these interconnected factors that quickly emerge, and it can look different from community to community and from place to place. Uh, I just saw a question or a comment come in chat about social workers and the value that social workers can bring. Have social workers, you mentioned community health workers is
Mm-hmm.
maybe a similar or connected, not the same thing, but connected idea. We've been talking a lot about technology. It can feel very distant from
Yeah.
those social needs. Have the social needs come up in maybe in rural health transformation or some of the other conversations you're having and stories you're covering about rural health and that being a center or central piece of doing rural health care better.
Yeah, it does come up. And I think that there are different approaches. I mentioned some of these platforms that have formed to help organize assets, I guess, for lack of a better word. So if somebody's lacking transportation, they can't get their prescription medicine, maybe they can't get to the doctor, or they can't do follow-up. Everybody knows that that is the challenge for, they can't get healthy food. right? Like the only store in town is a low income outlet because Walmart closed, right? Like there are challenges around that everybody knows and everybody acknowledges affects healthcare outcomes. And um, and people know it at the state level, people know it at the federal level. Like this is I was excited to see Delaware and Kansas both have food as medicine as part of their rural health transformation programs. They want to put money into that. So those kind of acknowledgments in how the states want to spend their newfound dollars are in those plans. Now, that said, these platforms can help connect people to transportation and so forth, but really the work, you still need people, right? You still need social workers or community health workers, those kinds of things. That's a very time consuming and money intensive operation. So that I appreciate the comment, and it's something that as a reporter I'm very aware of and I'm following. I am reminded of, I talked to Pima County Health Director Teresa Cullen, who is sort of nationally known. She's in Arizona. And she was super excited about their plan to do, I think they were community health workers. I don't remember the title, um, but to send them to people's homes. So they're getting grant money to make sure people are getting vaccinated, basically, in Pima County. And and her experience is very much that you need to be there, you need to be present, people on the ground. And I know there's people like that across the country. So that's sort of something I think that we're watching and seeing if it gets built up.
I appreciate the comment and in chat and just noting time. My cup of coffee's about out. We've got 13 or so minutes left. I You've talked about throughout our conversation some of the challenges, but also some of the successes and the innovations that you've seen. But if something that I'm interested in hearing you think about, you know, when we wrap up our conversation today, and when people hop off, they're going to go back out and wrestle with these challenges we've been discussing. And the policymakers are going to have to wrestle with these issues and make these decisions and determinations. When you think about your work and some of these tough and nuanced challenges and the decisions that lie ahead in navigating all this, how important and what do you see sort of your role as a journalist in sharing those rich, nuanced stories? And how can creating space to hear them and see that nuance, how can that help us do this better, make better policies, make better programs?
I mean, my hope as a journalist is sharing people's voices um, will help people understand each other better, right? I think it's a very polarized world that we live in right now. And in reality, when you go out and talk to people, they're just humans. We all want to get up in the morning and have a good day. We all want to care for our kids or feel like we're doing our job well and contributing to society. I haven't met anybody who doesn't want to feel good about themselves and feel good about how they relate to people around them, right? Unless they're terribly depressed. But but in reality, we're all humans. And so my goal as a journalist is to go out there and share the stories that other people have to help their voices be heard, because I think we can all learn from each other. And and that's kind of core to why I became a journalist. The other reason I became a journalist, though, and Wyatt, I think you know this because you listen to Where It Hurts, is my sister Maggie was in journalism in high school, and she made it look really easy. And I was like, okay, I want that hour too. And so I went to class and I got to go to the superintendent's office to ask a question, and they had to answer it for the school newspaper. And I'm a kid who grew up sort of on the wrong side of the tracks, right? Like neither of my parents graduated from high school. I'm very proud of them. They're the most amazing people, but it wasn't like, we were of the upper echelon of where I grew up. And that helps frame my lived experience. So the idea of going into the superintendent's office and they had to answer my question was really, it stays with me years later, right? All that is to say, as a journalist, I care deeply about sharing people's voices, but I also care deeply about making sure that the right questions are asked to the people in power and holding power accountable. And I think that there's always that's always been the case with journalism. And nothing has changed about that in recent years. We want to ask the hard questions of the people who hold the purse. And right now, the people who hold the purse with rural America are the people doling out that 50 billion. And whether that's at the federal level or the state level. And so, what's next for me as a journalist is when states have to file their updates at the end of August, they have to file their first annual report, which is very quick, right? And then they get a new round of funding in October, very quick again. Is watching how that money has been obligated, to use their word, where it's going, and if it's really reaching all those people we've been talking about. Now, I don't expect, or I don't think anybody expects it to reach those places immediately, but are we seeing the framework being built to help reach those folks and help lift up these rural communities that have poor outcomes when it comes to healthcare? And so, holding the people in power accountable is part of the job of a journalist, and that's what we're hoping to do. We're asking questions about where the money's being spent, how the money's being obligated, and what the outcomes will be. Those are things that they're expected to measure. And so we're going to keep watching it. At the same time, watching what happens with the loss of Medicaid dollars and the other realities that we all know exist in rural healthcare that I've been writing about, and KFF Health News and others have been writing about for years.
Yeah, the on a that's all very serious and meaningful work. On a less serious note, my when you mentioned going to the principal's office and asking a question, I thought of part of my motivation for being student body president in high school was that I could read the morning announcements over the intercom, which was a lot of fun. Um, and I don't know what that says about both of us, but it was a formative experience for you, and I think that everything you said, there's tremendous value in asking hard questions and creating space to learn from the answers to those questions. And I think the other thing, this whole series, the conversations we're having are built on the idea that nuance can inform better policies and better decisions. And when we create space to hear from and learn from and bring good data and bring good stories and bring good lived experience into it, we can have a fuller understanding of how this work is happening and the challenges and the solutions. And I think we've talked about the podcast that you did, the series, and we try to do that in our work. I think really created the space for that nuance, and you quickly learned that a lot of those decisions, a lot of the challenges that can seem easy on the outside are often a lot more complicated, a lot more nuanced. I want to call attention to my colleague Rebecca. She shared some resources in chat that folks have mentioned. We will also, as I mentioned, we'll have a recap where this recording will be shared, and you'll be able to watch it back, and we'll include resources as well. And that's a good segue for me. Thinking about resources, you talked about the work you're going to continue to do. I imagine there are folks here that heard something perhaps that they said, I knew some about that, but now I want to dig in. I want to learn more. I want to follow up on that. For those looking to learn more about rural health, to learn more about rural health transformation program and some of the other topics we talked about, what resources would you recommend they explore?
There's actually a lot out there. But if I'm sitting in Kansas and I want to know what's coming down the pike, I'd probably want to read the application the state filed. We have that on KFF Health News. If you go to the main KFF Health News page, you can pull up Trump 2.0, and then there's a tab that says Rural Health Payout. That leads you to all our stories about that transformation program since last year. And then also a map that has every state where you can click on available documents. We are in the process, literally, I have an email about it this morning, updating that with revised budgets that we are obtaining from the states. Of course, there's a federal site, tags.com, that has some of these grants on there too. You could explore that, but you've got to find the program. on that, and there's millions of grants on that. So you could go there too. You could also go to the Kansas website. I think they've got lots of materials posted on KDHE, including the most recent grants. As I said, NRHA has a tracking app for the contracts, and there's a few other private tracking app, like private foundations and stuff doing tracking too. I haven't talked to those folks, but if you're really interested in the Medicaid cuts, I would recommend Georgetown University's Centers for Children and Families. They have some great data and analysis on that. They've been one of the front leaders on it as well. And there's some at Princeton too. So there are resources out there on the Rural Health Transformation Program. And then, of course, KDHE is reaching out and holding webinars and stuff that you'll find on their website as well.
Thanks for, yeah, those all great resources and a couple of them in chat. My colleague Rebecca also dropped a quick survey for you. We'd love feedback on today's session before we conclude. And mark your calendars for next month. We'll be back with another uh, conversation. You didn't mention it. I will mention it for you. We've talked about it. It was over 5 years ago. It's still very relevant. The podcast that you did, Where It Hurts, and it, I think, is a great example of balancing the challenges and the strength and successes, and I think a lot of relevant insights to today's work as well. So I'll add that to your recommendations list, even though you're too humble to mention your own podcast. I really found it insightful and helpful for where we're trying to continue this work. Uh, we are going to wrap up here. One final invitation. Please take that form. Give us some feedback and stay tuned for a recap. This recording will be available as well as these resources that Sarah so graciously mentioned and covered. Sarah, thanks for taking the time today, sharing some of your work, sharing your insights with us, and we really appreciate it. I ran out of coffee. I don't know if you
I'm
about
about out
ran
of
out.
coffee too. I will say that I would love, I don't always have time to do all the stories that are pitched, but my email address is sjtribble, sjtribble at kff.org. I love hearing from folks and talking to folks in rural communities. Right now, I sit outside of DC, in my family home. This is where I'm at. I go into the office in DC, and when I'm lucky, I get to travel to rural areas, which I do quite often, actually. So give me ideas and let me come see you if I can do a story about it. So
Awesome. Well, we will share that as well, and I appreciate you bringing your lived experience that started on that farm at the edge of that dirt road and driveway we showed at the beginning with your family, and how you continue to bring those perspectives into the work you're doing to help us better understand rural health and this tough work that we're all doing. So, Sarah, thanks again for joining us. Everyone that took time today, thanks for joining. And if something resonated with you today, please share it with your colleagues and your friends when we post that recap. But with that, thanks everybody. We'll see you next month.
thanks,
Bye bye.
Wyatt.